You're listening to Medscape's In Discussion series on lung cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jacob Sands, Assistant Professor of Medicine at Harvard Medical School and physician in the Thoracic Oncology Program at the Dana-Farber Cancer Institute in Boston, Massachusetts, and Oncology Medical Director of the Dana-Farber Brigham International Patient Center. Relevant disclosures can be found with the episode show notes on Medscape.com or on the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Jacob Sands. Welcome to Season 3 of the Medscape In Discussion Lung Cancer Podcast series. Today, we'll discuss small cell lung cancer and some of the important advances in the field. First, let me introduce my guest, Dr. Hosse Borghaei. Dr. Borghaei is Chief of the Division of Thoracic Medical Oncology, Professor in the Department of Hematology Oncology, and Gloria and Edmund M. Dunn Chair in Thoracic Oncology at Fox Chase Cancer Center. Welcome to the Medscape In Discussion podcast.
Thank you so much. Great to be here with you.
Dr. Borghaei, I'd like to start out with something that is not necessarily brand new data, but it is a change in the field that was pretty dramatic in the incorporation of immunotherapy in the first-line setting with platinum etoposide. We saw Empower 133 and Caspian with atezolizumab and durvalumab respectively that became part of first-line therapy. Now, those were published in 2018, 2019. We saw no substantial difference in median progression-free survival and a 2-month benefit in median overall survival. But why is this so game-changing and so important in the first-line setting?
Simply because it's been nearly 30 years that we've made any kind of improvement in overall survival in metastatic small cell lung cancer. So if you remember, I often say if you go back to the study of carbopaclitaxel with or without bevacizumab in non-small cell lung cancer, the ECOG study, that changed overall survival by 2 months back then, and it was a big change because we hadn't been able to improve on platinum doublet in non-small cell. Now we have a very similar scenario where for a disease that is very, very aggressive, and we've been using the same platinum doublet chemotherapy for 2 to 3 decades, and all of a sudden with the introduction of checkpoint inhibitors, we have an improvement of about 2 months or so in overall survival. We were all happy that we were able to make some dent. But I think what you're hinting at is that it is not as significant of an improvement as we would want to see. However, for this disease, even some incremental improvements right now are welcome news. So I think that the excitement had to do with the fact that, again, in an intent to treat patient population, we were able to improve overall survival and hope that we can build on that. So I think that was the excitement, and that's why everybody keeps talking about those 2 studies, and the standard of care changed basically with the 2 presentations.
And the surprising thing also within it is the tail of the curve where we see these durable responses. And I think many of us now, or those who are treating enough patients with small cell, are seeing some of these patients that are years out from their initial diagnosis. And I know I have a handful who are now more than 5 years from their initial diagnosis, which was really unheard of before, but it's not enough. So in both of these trials, the treatment was ongoing. And so is there a point at which you're then stopping these immunotherapies, or do you do that for years indefinitely?
So unfortunately, I haven't been as fortunate as you are, having a number of patients going as far out. My experience is that majority of the patients who are on checkpoint inhibitors end up experiencing a significant fatigue and some other side effects. And because of the quality of life issues, we have had to hold treatment or discontinue treatment on a number of our patients and just follow. I agree with you that the tail of the curve is really interesting. But the unfortunate thing is that we still haven't been able to identify up front who those patients are who might maximize benefit from a checkpoint inhibitor. And of course, as you are very well aware, there's data that perhaps the inflamed subtype of small cell lung cancer could be a group of patients who could be benefiting from the treatment with a checkpoint inhibitor, and whether that is a fact that we can establish in a randomized, prospectively designed study or not remains to be seen. But I agree that there are definitely patients who have benefited from a checkpoint inhibitor. I would say that, I have a patient who I think is a long-term responder with really good disease control on the original Ipi-Nivo studies. There are those patients out there. Again, I think the challenge is how do you identify that patient population up front? What is it about those specific tumors or patient characteristics that we can learn from? And is that something that we can build on and sort of elevate that tail of the curve to include more patients who could benefit from these combinations? But to my knowledge, we haven't really been able to truly establish that particular subgroup and have that sort of coveted biomarker identified for that patient population.
Yeah, it's such an important point. You have a drug that could be a home run drug for somebody, but there's a higher likelihood that it's not going to be effective for an individual. It's a subset that has overwhelming benefit, it seems. And I'll say that's part of why I think it's so important to give in the first line setting where they have a shot at that, while they're also getting platinum etoposide, where the majority have a response to that, so they're going to be captured. And so that kind of raises the next topic. Initially, Pembro or Nivo were FDA approved and accelerated approval in the third line setting. So this was a single drug. So the slope of that curve was pretty steep drop off. But in the Pembro studies, for example, a 19% response rate, but 13% with ongoing response at 2 years. So remarkable outcome for that 13%. But, 81% didn't respond to therapy. Due to this, I think of Pembro or Nivo as being an important drug to consider in those who never got a checkpoint inhibitor. So for the most part, that's someone who had limited stage disease, got treated with chemo and radiation, and now has recurrence. Are you considering Pembro or Nivo in that setting? And I imagine, of course, if it's been more than 6 months, doing platinum etoposide plus atezo or durva is the easier answer. But let's say in someone, for whatever reason, that you're not doing that, are you considering single agent Pembro or Nivo?
I've definitely considered it. I've discussed it with patients. I think it's interesting how the approvals were actually withdrawn, or the use of the drug was actually withdrawn, because I agree with you, 19 to 20% response, some of them being durable. And again, with all the caveats that we've discussed, we don't know who the patients are and how to select them and all of that is there. But I was actually surprised that we were not able to have access to these drugs in the second line setting, because again, exactly the patient population that you are describing, chemoradiation, short interval, disease progression, what do you do with that patient population? I think checkpoint inhibitors can have a role in that setting. The question now, of course, is, how do you get access to it and all of that? But I do consider it for exactly the patient that you are describing here. And I do try to at least get patients introduced to the checkpoint inhibitors. I agree with you that if it is prolonged PFS and you have the opportunity to repeat the platinum etoposide, it's just an easy sort of transition to go and do chemo plus immunotherapy. But I agree with you that I do consider single agent IO in the patients who cannot be retreated with the platinum etoposide.
Now, in the second line setting, of course, small cell lung cancer becomes a different diagnosis, I'd say. In the first line setting, majority of patients respond to platinum-based therapy, some really long-term responders, as we've said, with the incorporation of immunotherapy. In the second line setting is where resistance becomes much more real and the durability tends to really shorten in what we've seen. But for a brief overview, topotecan has been a long-standing second-line approved therapy. This was initially approved IV after a publication in the JCO in 1999. That was versus CAV. The curves overlap each other entirely. But there was better symptom improvement in the topotecan arm, therefore leading to FDA approval. Of course, we also saw another publication in 2006. That was PO form of topotecan versus best supportive care. A partial response rate of 7%, and 44% of patients having stable disease, a median overall survival of about 6 months. Really, again, better symptom control on the topotecan arm. Again, that's versus best supportive care, but that led to the PO FDA approval. And then more recently, this was in 2020, we had the basket trial of lurbinectedin that showed a response rate of 35%, another 33% with stable disease, and a median progression-free survival of 3.5 months. The 6-month progression-free survival in the group with a less than 90-day chemotherapy-free interval, so this is the platinum-resistant group, we saw a 19% 6-month PFS. So that is a better response in the second line, or a more durable response in the second line than in the first line, for about 1 in 5 patients in that group. and 43% 6-month PFS in the more platinum-sensitive group. Toxicity profile was pretty good for lurbinectedin, I thought. 46% grade 3-4 neutropenia, but patients were not allowed to have primary prophylaxis. A 7% grade 3 fatigue, which in my experience seems about accurate. So, based on that data, what do you tend to use as your second-line therapy? What is your second, third line? And then I can mention irinotecan. Some people use irinotecan rather than topotecan, but how do you go about treating patients in second line, third line? What is your thought process on that? What is your strategy?
Again, I think it's a little bit of an evolving area and an area where we are desperately in need of additional drug development and treatment. So I'll be right up front to say some of the stuff that we're about to discuss. I've been either an investigator or continue to be an investigator in these drugs. And also, again, in full transparency, I've consulted with a number of companies. And to be honest with you, I have been using lurbinectedin quite a lot, actually, in the second, third line setting. If I have a patient with, I think, what can be described as platinum sensitive, I've been using the platinum sensitive patient population. We go back to the platinum etoposide and try to use that again. I think that's difficult. That's a difficult treatment for patients to tolerate. Myelosuppression, neuropathy, allergic reactions to carbo, all of these things are there, but it is a good, valid treatment option for patients. Short of that, I've tried to avoid topotecan and use more lurbinectedin in the time of progression, simply because I think, at least in my experience, patients tolerate it a little bit better than topotecan. The myelosuppression is real. I don't think it is quite as severe as what I used to see with topotecan. We use different schedule of delivery of topotecan. So, the standard 5K was always there, always toxic. I think there are publications from the ovarian cancer group using it on a weekly basis. We've used some of that in some of the patients in the old days. I didn't really like the PO topotecan approach quite as much, but I do understand that some of our colleagues have used it quite extensively. But so that was the experience with topotecan. And again, as you just suggested, the approval and all that was mostly based on quality of life improvement, not so much a lot of the clinical efficacy endpoints that we're used to see nowadays. And even though I don't think lurbinectedin has the required randomized phase 3 study, head-to-head comparisons and all of that, I think in general, I would say that in my clinic, the clinical efficacy and toxicity has been pretty consistent with what has been reported so far with the drug. So I've preferentially been using this agent in that setting.
Yeah, I think what you're describing is something I consistently hear really across the country. The other thing about lurbinectedin is it's once every 3 weeks. Sometimes I'll talk about time toxicity, where for topotecan, if it is once a day for 5 days in a row, that's quite a bit more. I know you said sometimes there are people that will dose it differently, but that's the approved dosing. So you said lurbinectedin as second line, and then in third line, is topotecan something you use, or do you use irinotecan? I tend to use irinotecan rather than topotecan, but I know there's broad variation in that, and there are some that are very confident and comfortable using topotecan as well.
I've definitely gone to topotecan in the third line setting in the absence of clinical trials and other options that, we sometimes have for patients. And again, even though we don't have a lot of data for it, I got to admit that in the third line setting, sometimes I have used agents like paclitaxel, which again has some clinical activity associated with it in the world of small cell. If I think that I am faced with a patient who might suffer from significant toxicities, again, especially myelosuppression with topotecan, and that could cause additional issues, then I've, again, preferentially used paclitaxel, even on a weekly basis for the management of patients in third or fourth line setting.
So we'll come back to paclitaxel, but let's maybe sidetrack for a moment on the myelosuppression that you mentioned with topotecan. And of course, we see myelosuppression with platinum etoposide. We now have trilaciclib that is approved just for platinum etoposide and for topotecan, particularly for myelosuppression. In small cell lung cancer, the data did not result in any real changes as far as efficacy in treating the cancer, but did show substantial, significant reductions in cytopenias. The primary endpoint of these studies being neutropenia, although frankly, to me, the value is not just that, but more so the anemia and thrombocytopenia, because it works across all cell lines, as opposed to, of course, the drugs we've had around, which have really been neutropenia focused. Now, one of the things that I thought actually was most compelling is something that Jared Weiss has talked about, in that the improvement in quality of life outcomes, particularly around fatigue, also seem to correlate with improvements in anemia, and makes me realize that there probably is some degree of fatigue that is attributable to anemia that I've likely underappreciated, because these drugs, of course, cause fatigue as well. They cause anemia. We say, okay, there's some anemia, but not enough that we would give a transfusion. But maybe if there was less of that, patients would actually have less fatigue and therefore feel better as well. I still don't use this for everybody, but it has been something that I'd certainly consider in everybody, depending on the circumstances. But can you walk us through some of the nuance of your thoughts around trilaciclib? What did you think of the data, and has it affected your practice?
Yeah. Again, really great question. And I think our practices are very much in tune. I'm not using it in everybody. I have to say that I am a recent converter. And the primary reason was a patient in clinic where we were faced with significant anemia and myelosuppression, despite the use of growth factor support in this particular patient. I have to say, I wasn't really all that impressed with the data initially. I've looked at it. I thought that this might be an additional expense they were adding to a regimen that works really well. The neutropenia, again, we've been managing with the standard growth factor support that we've had. But I have to say, again, this particular patient taught me a valuable lesson about the use of this particular drug. And I've really been happy that I've been able to use it, because, we're faced with a shortage of blood products throughout the country. We've lowered the hemoglobin level for patients who qualify for receiving blood transfusions simply because of all the need that's out there. And I wouldn't discount the impact of anemia and the fatigue that goes with it, in particular for a patient population who usually has additional issues in terms of cardiovascular, respiratory issues, because majority of these patients could have emphysema, COPD, and other issues. So I think it actually is something that we should take a little bit more seriously, because from a quality of life point of view, the fatigue that's associated with anemia is significant. So I am a recent converter. Again, we've had the drug in our formulary, and now I have a couple of patients that are actually receiving this agent along with their chemotherapy. It's a little bit of disappointment that we don't necessarily see an improvement in clinical efficacy the way we want to. One would have thought that being able to stay on schedule and on time with the delivery of chemo at doses that are prescribed would have had an impact on clinical efficacy. And hopefully there will be additional information down the road that would help us in that regard. But for specific patients, just as you said, not for everybody, I am happy that we have access to this particular drug. And again, I think additional information or studies are needed to really establish its place in the everyday clinical practice. But like many other drugs that we get nowadays, I think it's hard to give a blanket statement saying anybody who walks in through the door should be a candidate for X or Y. I think we have to be careful how we pick and choose on how we offer the particular treatments. I'm happy so far with the drug, and I am using it in select cases.
I am similar, although, I've also kind of looked back and thought, well, it showed improvement in health-related quality of life. That's obviously important. We highlighted topotecan got FDA approved on improvement in patient symptoms. And now other drugs, we say failed against topotecan when they didn't show superiority. Although, frankly, topotecan didn't show superiority in getting FDA approval either, except for maybe the PO form, which was versus best supportive care and against no cancer-directed therapy. I have to say, I do think more about this. Now, even with thinking about that, I don't think it's something for everybody. But my threshold for using it has certainly been lowered. And I do think those patient outcomes are a very important consideration. But along those lines now, you brought up paclitaxel earlier. I think as we get into third, fourth line of therapy, the tolerability of these regimens becomes particularly important. I agree with your comment earlier that weekly paclitaxel is very well tolerated. I dose that 6 weeks on, 2 weeks off. Of course, there's temozolomide, which is a pill form, and that's something that I consider particularly in patients that have CNS disease. But really, my answer is similar to what you had mentioned earlier, clinical trials. When patients qualify for trials, there is so much going on in the small cell space that I want to make sure we really have some time to discuss this. So highlighting that maybe is what we saw in the New England Journal with tarlatamab, a DLL3 bispecific T-cell engager, so binds CD3 on T cells. In the 10 milligram dosing showed a 40% response rate with quite a bit of durability to that, and generally pretty well tolerated. Early cytokine release syndrome, pretty much grade 1, 2. Some neurotoxicity as you get into cycle 2. But can you take us through the data a bit more and your thoughts about tarlatamab, and then we'll use that as a launch into DLL3 directed therapies in general?
Yeah, I'd be happy to. So again, an investigator on the tarlatamab study from the phase 1 onwards. And so I do think that the drug is an interesting addition, once approved for the treatment. Of course, still under investigation, as it should be considered investigational use in the clinical trial setting. So this is an area or a drug that I've had a lot of interest in just because of its bispecific nature. So by definition, these are bispecific T-cell engagers, as the name suggests, and as you said. So one arm of the drug engages directly the CD3, and the other arm of the study obviously goes after a tumor antigen, in this case, DLL3. So many of the listeners are familiar with the fact that DLL3 has been around for a while. We've had other drugs targeting DLL3 in the past, some with success and not some without. But the target is a relevant target in the world of small cell lung cancer based on a lot of the preclinical work. And again, as I said, some clinical trials. So bispecific T-cell engagers do actually, you can think of them as bringing the immune system and the tumor in close proximity and generating what we used to call in the old days as a immunologic synapse, so to speak. And again, the idea here was with the two arms, you can sort of bring the whole immune component into the tumor microenvironment, hoping for a better immune response. As you said, the New England Journal of Medicine article examined 2 different doses of this drug. So actually both doses come from the phase 1, like in any other study. But on the phase 1 clinical trial, a multitude of doses were investigated in multiple cohorts, going all the way to the 100 milligram dose. And the question here was, the higher dose versus lower dose, what was the clinical efficacy? So having treated a number of patients at our institutions on this trial, I have to say I've been very happy with the responses. And again, as you correctly pointed out, the durability, because we get a lot of drugs in the world of small cell where you might have an initial response, but unfortunately the durability isn't there. And at least so far, there were 220 some patients in that New England Journal article with the 2 doses of the drug. So we're beginning to have a relatively healthy data set of patients in terms of clinical data on toxicity. The response rate of 40% with a 10 milligram dose, I think is very interesting considering that these patients were pre-treated. The phase 1 trial, the response rates were a little bit lower, but about 30% of patients on the phase 1 had multiple lines of prior therapy, some of them beyond 3 lines of treatment, which is a unique situation in small cell. I don't know how you think about this, but yes, they're heavily pre-treated, but it's also a rare patient population with small cell that can go 3 lines of treatment and beyond and still have a good enough performance status and other factors as we require for participation in a clinical trial. So in the world of small cell, I think we have to be careful what we're talking about when we say, a lot of 3rd line and beyond patients. Still matters, but nonetheless, the drug does show decent durability and as a single agent, and interesting enough, overall survival as reported. Obviously, additional work is needed.
So we've highlighted the efficacy, which of course is very important when talking about a new drug. Now let's transition a bit to the toxicity profile. We of course saw some cytokine release syndrome. We also saw some neurotoxicity. Can you talk a bit about that profile and what you think of side effects looking forward with this drug?
The toxicity, because it's a T-cell engager, is real. The cytokine release syndrome can occur. But again, as you pointed out, majority of these were grades 1 and 2. And from a physician point of view, resource point of view, we're sort of trained to look at grades 1 and 2 as being manageable by physician criteria. Obviously, from a patient point of view, that's a different matter. Nonetheless, I think it's important to realize that many of these were managed without a need for prolonged hospitalizations or anything like that. But the neuro issues that you brought up are also important, and we do have to pay attention to all of these adverse events and kind of figure out how to mitigate some of these adverse events that are seen. So overall, I'm kind of interested in this class of drugs, and there are 2 or 3 other bispecific engagers that are now going through the clinical trial evaluation process. We'll see. We'll see what the eventual place for these drugs are, whether it's strictly in the 2nd line, whether it can be moved into the front line, and what the ramification of all of that is. Hopefully, we'll have access to more drugs with good response and durability for a patient population that actually is in desperate need of additional treatments. But overall, I think so far I've been very encouraged with what I've been seeing.
Yeah, I thought it was exciting data to see pretty high response rate and the durability and general tolerability, as you said. Of course, we also have the Harpoon trispecific T-cell engager, the Boehringer Ingelheim T-cell engager. So as you said, there's a class of drugs that seem to be showing some efficacy. And then there are other drugs in development that are DLL3 directed on top of some antibody drug conjugates. There's really so much more to discuss. So when we get back together in the next year or two, I think there will be a lot more to update on. And unfortunately, that's all the time we have to discuss small cell lung cancer advances. Today, we've talked to Dr. Hosse Borghaei. Thank you for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on lung cancer. This is Dr. Jacob Sands for the Medscape In Discussion Lung Cancer Podcast.
Thanks for listening to Medscape's In Discussion Lung Cancer podcast series with our host, Dr. Jacob Sands. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on lung cancer.